Hi, everyone. Welcome to the Oregon Rural Health Conference presented by the Oregon Office of Rural Health. I'm Rebecca Dober, Field Services Program Manager and moderator of today's session. I'm going to begin with some very brief housekeeping. First, I'd like to thank the partners whose support has made it possible for the Office of Rural Health to present the conference at no cost to participants. Many thanks to our gold partners, AllCare Health and the Oregon Rural Health Association, our silver partners, the Eastern Oregon Coordinated Care Organization and Oregon Association of Hospitals and Health Systems, and the River House on the Deschutes. Our bronze partner, our QI partners, and our copper partners, Westcom, the American College of Education, and Inquisic. Participants should have received an email with a link to our conference app. Use the app to visit our partners' virtual booths, enter to win prizes, network, and share photos of your hometown or region. To do the survey about the session, survey completion is required for participants seeking CE credit, and any completion gives you a chance to win a $100 gift card. So with that, let's begin. Our session today is about the impact of AllCare's First Tooth program and the impact of the COVID-19 pandemic on dental care. And I'm pleased to introduce your presenters for the session. Gary Allen, Dr. Gary Allen, DMD, Vice President of Dental Services for Advantage Dental. Hannah Cohen-Cline, Program Director for Research and Evaluation for the Center for Outcomes Research and Education at Providence, and Laura McKeane, Oral Health Integration Manager for AllCare Health. You can read more about the presenters on our conference app or webpage. And without further ado, I'd like to welcome Hannah. The floor is yours.
Thank you. So I'm going to start by giving a little bit of background on why this session is focused on oral health. Childhood tooth decay is the most common chronic disease of childhood, and it can result in negative impacts on a variety of different types of quality of life, for instance, nutrition or sleep or behavior. And it's largely preventable through good oral hygiene and connection with strong preventative oral and dental care. But low access to dental care is a problem, and it's the problem that disproportionately affects children of low income, those who are uninsured or Medicaid enrolled, and those who live in rural areas. And this low access is particularly exacerbated by a shortage of dentists, and in particular, an unequal distribution of dentists across geographic regions, which results in less dentists available in rural areas, and then a reluctance overall to accept Medicaid, frequently because of logistic barriers. Next slide. In Oregon, there are a couple different programs and strategies that are focused on increasing children's connection to oral and dental health. And a lot of these types of strategies will focus on either training medical staff on the importance of oral health or how to refer to a dental home, or having a medical provider administer basic oral health services, and then increasing Medicaid reimbursements for medical providers. And these all focus on integrating dental services into medical practice because children are more likely to have medical appointments than they are to have dental ones. And in particular, the Oregon Oral Health Program and the Oregon Oral Health Coalition launched the program First Tooth in 2009, and AllCare Health has been working to promote First Tooth in their region. And First Tooth is a program that incorporates all of the strategies I talked about before, both in the training around the importance of oral health and the referral process to a dental home, but also in allowing medical providers to administer these basic oral health services, especially oral health assessments and fluoride varnishes. Next slide. AllCare Health contracted with CORE, the Center for Outcomes Research and Education, to understand how their efforts to promote the First Tooth program and spread it to their providers in the region were impacting the use of oral health and dental services among children. Next. This evaluation had two objectives. One was to understand how the program impacted oral health assessments and fluoride varnishes. Those were the two activities that medical providers could provide. Next. And the second objective was to understand if the training around referral to a dental home then led to an increase in dental utilization provided by a dentist, any type of dental service, then broken out into preventive, diagnostic, and treatment, and dental sealants. Next. And so overall, what we found is that the First Tooth program did have a positive impact on connection to oral and dental services. The program itself was focused on children ages 0 to 6, but AllCare reimburses for a lot of these different types of oral health services up to age 19. So we looked at the two groups separately, and among the 0 to 6 range, we saw a substantial increase in the percent of kids who were receiving oral health assessments between 2014, when AllCare Health started actively promoting the program in their region, and 2018, which was the end of our evaluation period. Next. We looked at some factors that might drive this. We found that children were more likely to receive oral health assessments if they indicated English as their primary language and if they lived in Jackson County. But we didn't see a variety of we didn't see differences on a variety of other types of demographic groups. Next slide. When we looked at fluoride varnishes, we found something similar. This was a place where we could compare children who saw a provider who had been trained in the First Tooth program to those who didn't. And among younger children, those who saw a medical provider were much more likely to receive fluoride varnishes than those who didn't see a provider who had been trained by the program. And overall, this increase in the percent of children who were receiving fluoride varnishes was increasing over time. Next slide. We then looked at likelihood of receiving any dental service. Again, this is comparing children who had a visit with a First Tooth trained medical provider to children who had a visit with a provider who was not trained by the First Tooth program. And among older children, we saw that the kids who visited a First Tooth trained provider were more likely to receive any type of dental service than those who did not. Next slide. This difference was driven by an increase in preventive and diagnostic dental services. We did not see a difference in the use of treatment dental services or dental sealants between the children who saw a medical provider who had received a First Tooth training and those who saw a medical provider who had not. Next slide. So overall, what we concluded from this is that although the lack of access to oral health is a substantial issue among children in Oregon and among low-income children, Medicaid-enrolled children, and children in rural areas, it's also one that we really can impact. The First Tooth program did show that through these types of integration programs and training programs, we can increase the percent of kids who get oral health assessments, the percent who receive fluoride varnishes, and the percent who receive preventive and diagnostic dental services. It also showed that these differences, they showed up differently in different age groups. So a lot of programs really focus on the 0 to 6 age, as does First Tooth. But it's important not to disregard the impact that these programs can have on older children, 7 to 19, who also have substantial oral and dental health concerns and burden and need to be targeted in some of these programs. Next slide. So I'll hand it off now to Laura to talk a little bit more about COVID-19 and the impact that this has had on oral health.
Thank you, Hannah. And it's interesting because when we talked about doing this presentation for the Rural Health Conference, we were going to focus on first tooth training and assessments and how that has affected the kids in our region. And with the onset of COVID and the pandemic, we kind of decided to shift the presentation a little bit, and I invited Dr. Allen to join us to talk about how COVID has affected the DCOs, and DCO stands for a dental care organization, and CCO stands for a coordinated care organization. So go ahead with the next slide. Next slide. Thank you. So AllCare partners with 3 different dental care organization groups. We partner with Capital Dental, Advantage Dental, and Willamette Dental Group. Go ahead, next slide. So how did COVID-19 affect AllCare Health as a CCO? So we did start exploring telecommute options for staff. We did increase cleaning with the janitorial service, as many people did. We decided to discontinue all of our staff home visits and hospital visits. We have a lot of community health workers and care coordinators that visit staff, so we decided to stop that. We did close our doors to the public. Of course, employees still come and go, but we do have public that come to the building to visit us or to make payments for the Medicare Advantage line of business, and we discontinued that. We did increase our communication with our dental partners and our community partners to make sure everyone knew that even though the doors were closed, we were still open for business. Next slide. So one of the things that AllCare did is we decided to come together. I'm part of what we call an integration team, and there's a team of 6 of us, and that includes health and integration support, social determinants of health, community engagement, and then my role with is oral health integration. So we decided to come together. We received some funds from the Oregon Health Authority to distribute to our partners that needed help. So we called this the COVID-19 Resiliency Fund. And you can see there we distributed since April almost $1 million to 80 plus community-based organizations in the area. They improved their capacity to stabilize and promote health, which was important. We have a lot of CBOs in our community, which is the community-based organizations. They serve our region very well, and we wanted to make sure that we could assist them moving forward as they're working toward addressing these long-term effects of COVID. Next slide. So these monies were also in addition to in-kind donations and volunteer support that we had. One of the examples is we compiled a list of members who needed help accessing food. So we worked closely with the local food bank to see how we could develop a system for food deliveries. So our care coordinators actually placed orders a few nights before they picked up the boxes of food that the food banks assembled. And then we were able to deliver these. We also were able to tailor the boxes to any allergies or special dietary needs that people had. And then they picked up the boxes behind the food bank and they delivered them with very little to no social interaction at all, which was really important. Next slide. So how did we support our dental partners, such as Dr. Allen with Advantage Dental, who's here with us today? On March 25th, all the dental offices ceased normal operations, at least until June 15th, and that was as per executive order of the governor. So what does that look like? It means you're only probably going to see emergency patients until otherwise instructed. So they did continue to see emergencies. They used the ADA dental emergency guidelines to triage patients. One of the things that we did as an organization is we asked for an access plan from all of our dental partners for providing extended services to members, because we knew once this order was lifted and members could start seeing the dentist again, there was going to be a pent-up demand because appointments had been canceled. So we just asked our partners to give us a plan of how they were going to address that. Everyone did, and it so far has been going really well. Next slide. So the other thing that we did, we received weekly updates from our partners. Advantage Dental would send a weekly update to myself, and our chief quality officer was one of the most, I will say, detailed weekly updates that I've ever seen. It was very, very clear and concise, and at the same time had a little bit of warmth to it. So we knew that the members were going to be taken care of. This report also included the number of emergency patients that were seen, the number of emergency patients that were seen in the actual emergency department at the hospitals, and the statuses of all offices regarding the open locations that the office might have. And Advantage Dental really did some great work with teledentistry implementations and let us know where this was taking place all the time. Next slide. So where do we go from here? We know that COVID is still here. I don't think it's going anywhere anytime soon. On May 1st, though, of 2020, the governor, her executive order, did allow dental offices to open back up for normal operations. Now, with that being said, it's not something that the dental partners just said, oh, okay, the doors are open, come on, we're going to resume normal operations, because I'm sure Dr. Allen will expand on that, but that is not the way things happened. There was a lot of personal protective equipment that needed to be ordered. There was plans that needed to be in place. So it was a pretty heavy duty for these dental offices to be able to do that. We did donate over $35,000 out of that resiliency fund to the dental partners. A lot of it went toward oral health needs, mostly the personal protective equipment. I had one partner, one of our FQHCs, our federally qualified health centers, they were telling me that just the gowns that the dentists and assistants and hygienists needed to wear were like $9 each. So that's a pretty heavy expense when you're seeing, 30 patients a day and you have 20 staff members. So, and you have to change these gowns after every member. So that was a pretty expensive expense for these offices. So catching up with member appointments, I talked a little bit about that before as far as an access plan. They've done a tremendous job of getting these patients back in who have their appointments canceled. We did hear some of the members, they were pretty disappointed their appointments were canceled, especially if they were waiting for a denture to be made. But the dental partners did such a great job of communication to the members, letting them know the status of reopening of the offices. And again, Advantage Dental was very concise and thorough in their weekly updates to AllCare, which I appreciated very much. Next slide. And so with that, I'm going to turn it over to Dr. Gary Allen. He's the president of Advantage Dental Group and the vice president of clinical services. And I've had the privilege of knowing and working with Dr. Allen for quite a few years now. He's an amazing dentist and just a great person to work with. So Dr. Allen, I will turn it over to you.
Thank you, Laura. And as mentioned, my part of this presentation is really to focus on how our dental plan has responded to the COVID pandemic. And I will also talk about the profession at large across the nation and how we have responded as a profession. In the spirit of full disclosure, I will mention that the first half of my professional career, 26 years, was spent as an Army dentist before I retired in 1999 and returned to Oregon. And I mention that because I do have a tendency at times to lapse into military references and military terms. And it explains why I chose this particular slide to introduce my presentation. And I did this as a reminder that we've been through a pandemic before, so it's not unprecedented. And eventually things return to normal. And I think the good news is we are much better positioned as a nation and as a profession to respond this time. And I did have 2 tours of duty at Walter Reed, but no, that's not me doing oral exams there. It was sometime after that, so I was there. Next slide, please. Thank you, and I want to begin with just give you a little background on Advantage Dental. We, as Laura mentioned, are a DCO dental care organization. We have been around since the origins of the Oregon Health Plan. Geographically, we are the largest DCO, and we serve 350,000 members, over that really, through our contracts with 13 of the state's DCOs, and then a direct contract with the Oregon Health Authority for members that are not assigned to a CCO. And I will mention that number 350,000, more than that now, and continues to grow since the onset of the pandemic, has increased by, for our membership, about a little over 13%. Our delivery system is a hybrid network of our owned staff model dental clinics with our own employed dentists and dental assistants and hygienists. We also utilize a team of community care hygienists and dental assistants that are mobile and take services into the community for members that have difficulty accessing a fixed dental facility. Next. And this is a graphic representation of the geographic distribution of our offices across the state. On the upper left is our own offices that we operate and our own employed dentists. And then on the right is when you overlay that with our contracted primary dentists, and you can see that we have access points through most of the state. So our members can easily access one of our facilities or one of our contracted dentists. I made no attempt to use an icon to pinpoint everywhere where our community care teams go. They, in 2019, worked in 30 counties, 666 different sites. Many of those they visited more than once, and almost 40,000 unique patients. And many of the patients they saw more than once to provide assessments and preventive services. Next. And I should also mention our parent organization, DentaQuest, because they were very instrumental in how we were able to respond to the pandemic the way we did. DentaQuest acquired Advantage Dental in 2016. They are a national organization that provides Medicaid services in over 30 states, primarily as a payer, although they've recently gotten into direct patient care through the acquisition of Advantage and a couple other dental groups in other states. And having DentaQuest as a partner in a parent organization was very helpful, particularly, and I'll use the example of trying to source PPE and the difficulty with that. By having a national organization that was able to leverage its buying power and dedicate a full-time team to sourcing PPE nationally and internationally, trans-shipping among states if necessary, if we were short and Alabama had an excess, then they could organize the shipment within their own organization. And I should also mention that DentaQuest is a thought leader in the dental industry and dedicates a lot of resources to research, publications, webinars. So they were very helpful also as we had to sort through all the different guidelines from the CDC and OSHA and the American Dental Association. Their teams were able to put this all together into more concise packages. As I mentioned, they did publications and webinars and assisted us with development of our operational manuals. Excuse me. And the resources that DentaQuest put together were made available to the entire profession, so it was not just Advantage and their own dental organizations. Next, please. So review the timeline. Laura mentioned that the governor's executive order required us to go to emergency-only care, and then she followed that not too long afterwards, allowing us to resume routine care. However, there were limitations in her executive order as constraints and guidelines that we had to comply with. So it was not just picking up the drills and starting dental care again as we were before the pandemic. And then we're now into this for several months, and we've achieved some level of normalcy or new normalcy. And within our own organization, we've referred to this as how we've responded as phase 1, phase 2, and phase 3 of the pandemic. Next. So initially during phase 1 for emergencies only, we started with 11 dental offices that we opened up. And we realized that this would not be adequate to serve the population assigned to us. But keep in mind, as Laura mentioned, and as everybody's aware, PPE was very limited. Also keep in mind that schools were closed at the same time. So a number of our staff suddenly found themselves with no daycare. So it took a while to actually inventory our PPE, consolidate it, get it to the offices that were open, and recruit and train staff that were able and willing to work in our offices. We followed those initial 11 offices every week or 2 weeks by adding more offices as PPE became more readily available. We're able to train more staff, and by the time we got through phase 1 or the emergency only operational phase, we had 41 offices that were open and seeing patients for emergencies only. We were also doing teledentistry during this time. We had been doing teledentistry in some selected sites. So it was relatively easy to transition, expand our platform, and train up additional teledentists to make those services available to our membership and even beyond our own membership. During the emergency-only phase of our response to the pandemic, we saw almost 3,000 emergency patients in our offices, and over 1,000 of those were not OHP members assigned to us because we opened up our services to all of the communities, members in all the communities. We also did almost 400 teledentistry consults. And as I mentioned, during this same time, we were developing very detailed clinical operations manuals, training our staff because this was new to them. Dental staff, clinical staff do not typically work with N95 masks. So that was a new experience for them. And then within our corporate office, our member services and provider relations teams were regularly monitoring and surveying our contracted dentists so that we could assist in navigating patients to care to the location that would be the most convenient for them. Next. And then in phase 2, when the governor opened up to routine care, as Laura alluded to, there was a lot of pent-up demand. However, we still had a lot of the same constraints with PPE and staffing. So it took us a while to ramp up. We initially responded with just the 41 offices that we had open throughout the emergency-only phase. And then we slowly added additional offices as more PPE became available to us, more staff were trained. This actually required, because the CDC guidance and OSHA guidance was changing at the same time, so we were continuously revising our operational manuals, and it meant continuous training and retraining of our staff. It was not smooth from the standpoint of being able to just return to normal operations. We had to stagger schedules for our patients in an effort to limit aerosol generating procedures in compliance with CDC guidelines. We were scheduling those at the end of the day to allow the aerosols to settle so that we could thoroughly clean our offices between days and between patients. Next. And you're probably familiar with some of the publications that looked at the relative risk profiles of the workforce, and in particular the healthcare workforce. And they consistently rated dental personnel at greatest risk. The New York Times article just spoke in terms of dental staff in general, but the Virtual Capitalist article actually called out members of the dental workforce and listed dental hygiene as number one, dental assisting as number four. And this information was not lost on our staff. They had great concerns, and we wanted to make sure that we addressed their concerns. And that's, again, the reason why we were very careful in our training and sourcing of PPE, making it available to our members. We didn't cut any corners, and making sure that they felt safe as we resumed routine care. Next. So our adjustments to the new normal, teledentistry, it's here to stay. As I mentioned, we had been doing teledentistry, and we actually had initiated a survey of our members. And surprisingly, teledentistry experience was very well received by our members. That came as a bit of interesting information to us, because typically dentistry is something you do to patients and not something you do with patients. So it was interesting and refreshing to hear that they received it very well. Just from being able to consult with a dental professional to get reassurance that their particular problem could either wait or to get reassurance that they would have the endorsement of a dentist if we needed to schedule them for a visit in one of our offices that was open. In some cases, through the consult with a dentist, we were able to bypass the primary care dentist and refer directly to a specialist. So we developed some efficiencies there. In addition to teledentistry, we expanded our practice audits. We've always done practice audits to look at the safety and compliance of our offices with infection control, sterilization, but we added some very specific compliance monitoring for the COVID pandemic and what the guidelines were as far as screening of patients, taking temperatures, all the things that you're all familiar with in healthcare offices now. We reintroduced minimally invasive dentistry. This is not a new concept. It's been around for decades, but has not necessarily been well received by the dental profession. And what this means is there are things that you can do to treat decay and other oral health problems short of drilling on a tooth and utilizing aerosols. And I'll just use the example. We've known for a long time that early decay in the grooves and pits of teeth can actually be sealed in. You don't have to drill it out. And guidelines for how you do that and when you do that have been available through the American Dental Association Center for Evidence-Based Dentistry for a long time, but it's not widely done. So reinforcing that with our providers, that there are things that we can do for our patients to treat the disease mitigate the disease without actually having to go in with drills and create aerosols. There are other things you can do to manage aerosols and limit it within a dental office. In some cases, our dental hygienists, we had to retrain them because they're used to utilizing ultrasonics for doing cleaning of teeth, and particularly deep cleaning of teeth. But before there were ultrasonics instruments, there were hand instruments. So it was just reminding them that that was still available to them. So when we talked about training up staff, it was not just utilizing the expanded PPE, but also just getting back to the basics of dentistry. Schools were closed, as were a lot of other sites where we were traditionally providing community care services. So we had to be innovative in how could we address community care without actually having access to them in the schools. And what we've done is we've employed hygienists with teledentistry as well. And we are staffing offices with our community care hygienists on days that are underutilized. Our dentists work 4 10-hour days, so we would have space available on a Friday, for example, or on other days, or on a Saturday. And we move a community care team in and advertise in the community that services were available for school children and other members of the community. And with all of that, we've been able to achieve about 70 to 80% of capacity that we were seeing pre-COVID. And it's been a slow ramp up. We were ramping up at a little bit better pace, and then, of course, the wildfires hit. So that slowed us down a bit as well. Next. And I want to show this slide. This was an article that was in the New York Times and it was picked up by a lot of other publications. And it highlighted actually our community care team, and that's one of our expanded practice dental hygienists, Tiffany Foy, who works out of the Bend office. And it just called attention to the fact that students from low-income families are the patients that are most affected by us having to withdraw from community care. We're slowly getting back into some sites and even into some schools, but obviously not to the extent that we were serving the schools in 2019. Next. And this is from the Center for Medicare and Medicaid Services. This was part of a slide deck of a presentation they did where they reviewed preventive services for children across a lot of different types of services. And would point out that dental services have been disproportionately affected, although all preventive services on children have been reduced. Dentistry, dental services has been disproportionately affected for kids. So that's a concern going forward. Next. And this is a summary from data that has been compiled by the American Dental Association Health Policy Institute. Beginning of the pandemic in March, they started doing biweekly surveys of dental offices. So this is national data. This is not limited to just Oregon, and it's ongoing even now. However, things have pretty much normalized in the dental industry in September, late September. So this is representative of how things are looking. But as you would expect early on, very few dental offices across the nation were open. But now 99% of dental offices are open and seeing patients, although the majority at significantly reduced capacity. And then, of course, as you would expect early on, the patient throughput, patient volume was limited, and now it's at about 81%. The most recent survey, which I did not include in this slide, actually showed it declined a little bit to 80%. So that mirrors what we're experiencing in Oregon in our offices, because we are at about 75 to 80%. And then they also had additional questions that they asked dental offices, excuse me. And one in particular was to monitor the availability of PPE. And you can see that it continues to be a problem, particularly with N95 masks and gowns and disinfecting supplies. The Health Policy Institute also partnered with an organization that surveyed consumers as far as their attitudes towards dentistry. And this independent survey group has found and published that about 75% of patients are either have returned to dentists or are comfortable visiting a dentist. An additional 9% would be willing if they got reassurances that it was safe. But there are 14% of the population out there who are waiting for a vaccine, or just declining to go into the dental office. So when you review all of the data and all of the information available, the American Dental Association Health Policy Institute estimates that the upper limit with all of the constraints that we have for being able to treat patients is at about 85%. So that's our goal too, is to get to 85%. Next. So what can we expect going forward in our offices and in the dental profession? Dental dentistry, enough said about that. At the peak of when we were in our emergency only phase, about 10% of our visits were teledentistry visits. It's now normalized at about 3%, but we actually want to ramp it back up to around 10%. And this is not in lieu of our dental office visits, but this is to make additional capacity available to our members and expand utilization. We have to be innovative and look at our scheduling with the constraints, and how can we make better use of our offices. Where we have available staffing and available PPE, we've opened some offices for Saturday care, but not able to do that everywhere. PPE supply interruptions, we expect that to continue. There are investments in additional mitigation strategies for how do you control aerosols in a dental office through the HVAC systems, filters, high volume evacuators that can be utilized right at the point of service. All of this costs money. And what they're finding with the publications have shown is that the cost to provide dental care has gone up by an estimate of 15 to 20 per patient. And some of that is being passed on already to patients. Dentists are billing for the increased cost of PPE, and you can expect that that's going to increase. And in their surveys, the American Dental Association has found that the majority of dentists do intend to raise their fees when they get to the next year in renewal of their contracts. And there's concerns about Medicaid dental funding. There have always been concerns, less so I think in Oregon, I hope so in Oregon, but certainly in other states this has been raised. We're concerned in Oregon about perhaps erosion of dental benefits. Adult dental is not a mandated federal benefit, so it's always at risk. And then if there are constraints on the state budget, they have traditionally in the past turned to dental as a way to save dollars at the cost of prevention, at the cost of overall health care, unfortunately. And in other states, again, going back to the American Dental Association Health Policy Institute surveys, some dentists that have been surveyed have said that they really intend to quit seeing Medicaid patients. We have not seen that with our network. here in Oregon, I think it's helpful that we have a global reimbursement model here in Oregon and a capitated model, and we pay our providers on a capitated basis. So that helps with retain them, and the money continued to flow, although at a lesser rate throughout the pandemic. Then you can expect that there will be COVID-19 testing in dental offices. Some dental offices in states, other states, are already doing this, particularly as the reliability of testing saliva continues to be shown to be effective. Then eventually you will see vaccinations in dental offices, as I predict. In Oregon, everybody is aware, I think, that legislation was passed that allows dentists to deliver vaccines, and this was pre-COVID. And graduating dental students have been trained, so they're ready and eager to do it. It's not a simple transition, but I think that you can expect that that will happen in the future. Next. And that concludes my summary of how this has impacted our dental plan and the dental profession. Final concluding remark is dentistry is safe. It's always been safe, and I actually think it's probably safer with a lot of the new measures that have been put in place to protect the public and to protect our staff. So with that, I will turn it back over to Rebecca.
Thank you, Hannah, Laura, and Gary. We'll now go to the question and answer session. Hi, everyone. Thank you, Hannah, Laura, and Dr. Allen. I'm going to jump right in to the Q&A. Starting with a question that came in to the Q&A box during the presentation. Do you think teledentistry will continue post-COVID, and in what ways? Maybe you can just expand on that a little more, what teledentistry is going to look like in your perception post-COVID.
Well, certainly for our group, it is going to continue and to expand more innovative ways to use dentistry. And for example, with our expanded practice community, can we, and we already have to some extent, put teledentistry equipment in their hands and allow them to go into community sites and connect with a dentist that way asynchronously. And then we are implementing it throughout all of our offices. So that our dental offices and employed dentists will have the capacity to do synchronous real live video with patients as a means of making it more convenient for them if they're have a problem that they're not sure about. Is it something that needs to be seen right away for an emergency? So short answer again is yes, it's going to continue. And that's been demonstrated not just within our own group, but as I read the literature, I think a lot of dental plans intend to do the same.
We have another question from the chat box. How has the layout of the dental office and exam areas helped or hindered care adapting COVID protocols?
It's been a challenge. And in particular, some of our offices, some of our rural offices, which don't have a lot of space available for social distancing, but we've adapted. Some of our larger offices, not so much a problem, because traditionally dentistry is used an open bay concept of without isolated rooms. Then the mitigation of aerosols. When you need to use aerosols, we don't use as much aerosol as we used to, but it presents a challenge So some innovative things need to be done as far as scheduling, staggering schedules, staggering use of rooms. So it has slowed down. That's contributed to the our slow ramp up to our pre-COVID capacity. And the expectation is we're really never going to get there. And that's why we have to look at expanding schedules and looking at other innovative ways.
Great. And we had a few questions come in on the app, and I'll try and address them before we get to time. Hannah and Laura, there's a question. What was the effect on practice after 6, 12, 18, and 24 months of the first tooth treatment? So that was, what was the effect on practice?
Hannah, you have the data.
So we didn't look at changes to the practice itself in the evaluation. It's one of the things that I think would be an interesting next step, but we didn't look at how the dental office or the medical office shifted with the program. In terms of changes in the outcomes for kids who had gone to the dental office or medical office where someone had been first tooth trained, everything there we were looking at year by year, so it was 12-month outcomes. So we didn't have a breakdown by 6, 12, and 18. It was just the overall, in that year, they saw better connection to dental care and more receipt of oral health services. Laura, I don't know if you have anything to add about changes in the practice itself.
I don't think so. I was just going to piggyback on that. There was another question that came in the app as well. At what age did we recommend starting this program? And I would say, and Dr. Allen, I welcome your input, but I would say as soon as the first tooth erupts, we want to start getting some care, some fluoride on those teeth.
No, definitely endorse that.
And then I think we have time for one more before we go. What impact did the closure of business to the public have on the overall uptake of dental services?
Well, certainly there was a lot of pent-up demand during the initial closure, and we saw that in our offices, and it was reflected in national data as well. And when patients started to get back in, we saw some progression of disease. Although, quite frankly, dental disease, dental decay, and even periodontal disease progressed very slowly. The bigger concern was those patients that had an existing infection, trying to navigate them to care and making them feel safe that they could come in for care and get that taken care of so they didn't end up in a hospital emergency room. And that's where teledentistry was beneficial, and keeping several of our offices open for emergency services that we would triage and determine which were legitimate emergencies. But going forward, and there's been other reports in the literature, not necessarily related to the delay in care, but just from the pandemic and the stress associated with that. You've probably seen reports of increased incidence of cracked teeth, clenching, and bruxism, and just the stress effects. And that's certainly been reported and seen nationwide by dentists and within our own offices as well.
All right. Well, that puts us actually, we're a little bit over time. So I want to thank everyone. Thank you all. This was really great presentation on such important work. We really appreciate you being here with us. I want to remind everybody that any additional questions that haven't been answered from the app or that you want to send in afterward, we will follow up and we'll post all the questions and their answers with the recording and the information from the presentation on the Office of Oral Health website. Again, thank you, Hannah, Laura, and Dr. Allen. Really appreciate your time with us here at the conference. And I hope everyone will be able to stay on and jump to the next presentation with us. Starting at 10, we have partnering with parents in rural communities, resources and links to support children and youth with special health, developmental, or mental health needs. Again, that starts at the top of the hour at 10, and the presenters are Tamara Bakewell, Melissa First, and Diana Hansen. Thank you, everyone, for joining us. We really appreciate all the work you're doing. Thanks.
Absolutely. Thank you all.
Thank you.
Bye-bye.